thank you everyone for staying on for our final panel of the day. Once again, my name is Stephanie. I'm with the Bisnow team. I want to remind everyone that after this panel, there will be time for more speed networking. Make sure to also check out the expo pages in the lobby. And before we get started, I want to say a huge, huge thank you to our sponsors for this session, Climatech and Ewing Cole. And without further ado, I want to introduce our final panel where we will be discussing medical office building design considerations and retrofitting existing facilities to accommodate for pandemic needs. That was a mouthful. So I will pass it over to our moderator for today, Lori Philman from Climatech. Lori, take it away.
Great. Thank you, Stephanie. Good afternoon. I'm Lori Philman. I'm the Regional Sales Manager with Climatech. And at Climatech, we work with growing healthcare networks to provide innovative, future-forward technology solutions. Thrilled to be here today. Thank you. With that, we're going to do interviews, or introductions. Alex, I'll start with you.
Thank you. Good afternoon, everybody. My name is Alex Bolanos. I'm the VP of Development and Acquisitions for United Surgical Partners. We are the largest owner-operator of surgery centers in the country with operations in over 31 states. Glad to be here today and looking forward to a productive session.
Great. Thanks, Alex. Alicia?
Thank you. I am Alicia Wachtel with Cedars-Sinai, Executive Director in the Facilities Planning, Design, and Construction Department. And my prime responsibility is working in the growth and expansion strategy as we grow out of our historic campus into the communities.
Fantastic. Thank you. And Jeff.
Thank you. I'm Jeff West, Vice President for Real Estate Strategy and Operations for Providence St. Joseph Health. What that really means is that outside of real estate, I also have construction for the region in and out of the acute settings. My teams handle facilities, plant management, and also EVS for our 11 hospitals here in Southern California.
Thank you, Jeff. And Trey.
Thank you, Lori. I am Trey Arnold with Ewing Cole, and I am the Regional Director of Healthcare Architecture in San Diego. And a little tidbit of information, I'm completely changing this up because of that theme music at the beginning. So a little tidbit of information as far as how you can survive a pandemic in lockdown. You know how every day seems like Monday? So you need a music genre for each day of the week. And that music there reminded me, it should be Wednesday. It's like gives you a little hump to get to the middle of the
right. It's the energy level up.
Day for me.
Dude.
Love it. All right. Well, with that fascinating tidbit, Trey,
Here you go. Leave it to me.
You get question number one. And that is, the pandemic has shown us the need for flexibility within the built environment. Moving forward, how do you future-proof your building and infrastructure to provide flexibility and resiliency?
Yeah, so the buildings that I'll be speaking to primarily are the ones that were probably hardest hit during the pandemic, and that was, the acute care environment, those type of facilities, hospitals, urgent cares. Those are the ones that were hit hard. But before I get into what we'll be looking at as far as changes, it will definitely, when you're looking at your, on the planning side as a designer, we want to understand the program and the business plan. What is the delivery model? And that will truly need to be vetted now in light of these circumstances. Can it be adaptable, and what areas will we need to make some modifications to capture that and make it very flexible so that what you're delivering to the patients can be addressed in the building. But big picture, a lot of the things you won't see as obvious. A lot of it's going to be more behind the scenes, interior related, as far as the interiors. But on the outside, you might see where your patient drop-off area might get a little bit larger to handle, drive-through type scenarios. Waiting rooms might be more compartmentalized. And so a lot of what you'll see is it's kind of zoning and breaking down the interior of the space so you have more control as far as air movement, patient movement, receiving patients and the flow of patients through the facility. So another item would be in the, for example, entrances in the ED or ER area. You might see multiple entrances now to enable staff to compartmentalize and break up for, have an area of the ER that's more decontamination or infectious control reasons, so that those patients can be more controlled in that environment. Other areas, that's patient, you have staff concerns as well. And where the staff are, and again, hats off to all the first responders in this environment, how brave they were. But that's a very important element that needs to be addressed as well. And so areas for, that address the staff as far as lounge, they need to be really addressed in the sense of something that someone can really get away and get out of the quote unquote battlefield, if you will, and have a place to really have some an area to regenerate. Mm-hmm. Facility management, that's another area with PPE, material management. There's a lot of elements that are flowing in and out of this space. And they'll be necessary to have kind of a more rugged infrastructure, storage capacities for PPE, accessibility. I think donning and dumping of this material, patients, it creates bottlenecks when you're serving the patients. And so these areas need to be kind of broken out. Corridors will probably get larger, a little bit more space will allow that. I could go on and on. Flexibility, adaptability, that's like and resiliency. In light of a few weeks ago with the crazy weather conditions, resiliency is a big deal for these facilities now. Right. A lot has to be adapted in the clinical arena as well. So it won't be big picture wholesale type changes. It'll be subtle, discrete changes. You may see, if you're waiting in the waiting room, you may see maybe some med gas sitting in there, or some other rooms. For example, out in the corridor, you might see more utilities that will allow these spaces to be adaptable and flexible for patient needs. Okay. So it's very balanced.
Let me just jump in here, Trey. Yeah. Talking about adapting a full hospital build for a once in 100-year event. So the question that I would have, and Alicia's shaking her head, but I think more, at least in the where we sit today with either aging infrastructure, Alicia's got a 900-bed building downtown that's pretty big. Alex is on the cutting edge of building some smaller stuff with his outpatient services. So I think the real question we got to ask ourselves is, should we be prepared to adapt as these disasters come? Because I think all of us were ready, the ministry level, at the hospital level, for first-person shooter, earthquake, fire, any of those. We all have emergency plans. We all follow this protocol, all those types of things. But the pandemic kind of caught us all by surprise. So as you look at new builds for your clients, are they saying, golly gee, I want to build a pandemic floor? We spent a month making everything negative when we didn't need to, right? So we pulled all that stuff off in April of last year and kind of started over. So, and those are the questions that I would have. It's tempting to build for that, because when we were in the thick of it, and you're dumping a bunch of oxygen through a 2-inch pipe and it should be 4 inches, right? Because of an older building, those types of questions. We absolutely were thinking that. But today, in the light of day where COVID is simply a part of our patient population instead of dominating our patient population, what should we be doing? I would ask the question to the group.
Alicia or Alex, any further comments?
Yeah, we have, you put it in great perspective, both of you, but especially Jeff, because now I'm on that side of the world, on the owner side. And we have our 900-bed hospital. We have our Marina Del Rey small hospital that was really overtaken by COVID patients. And we have a hospital that's about to start construction, which is a replacement for Marina. So what we did, Jeff has one at least under construction. We went and we looked at the design it's approved by OSHA, right? To see, okay, would this have worked for the pandemic? Would this have worked? So that was a great exercise. The short of it is I would stay with HVAC and zones, entry points, exit points, separation. It's so expensive to build. Some of the things that Trey, you propose, I think are great ideas, but we probably couldn't afford them for this kind of event.
Good comment.
Fantastic. Yep. Alex, anything else?
No, I would agree with the comments. I think on the surgery center piece, what we learned is that certainly as we look at going forward designs, particularly in lobby areas and waiting areas, perhaps accommodating some bigger space for that would be appropriate. But to Jeff's point, and this is a once in 100-year event, and it's difficult to pivot quickly when you're in the services business like this. But you do think about going forward, what new designs could entail. And given the fact that we could be seeing more pandemics in the future, I think there'll be some slight modifications, at least on the surgery side of the business, where we can see some tweaks, particularly in the waiting areas, to provide good social distancing and good workflow for those patients.
Great. Thanks, Alex. And this actually is a really good segue for our next question, which Alicia, will start with you. How have hospitals and healthcare facilities retrofitted their buildings to combat the spread of the pandemic? Twofold question. Then will developers adopt the same facility changes for future developments?
Yeah, it's good that we're asking that question. Well, on one side, we're saying, what could we plan for? Everything we've already done because we had to. And we had to do some of the things to take care of our patients. They showed up. So the first thing I would talk to everybody, think about is what hit us the most when the pandemic started was that we could only treat COVID patients. Right. So you have a 900-bed hospital, and because we didn't know what this was, how to treat it, all scheduled procedures stopped, right? All other patients, we didn't know what to do with them. We were trying not to get patients in. We stopped so much care, both inpatient and outpatient. And what that did is two things. One is affected patients the most. Second, our revenue was tremendously hit. So everybody that's on this call wants to build things, right? So there you go. We couldn't take care of those patients. So when you think about a hospital, can it be compartmentalized? Can we treat patients that are infectious and patients that are not? How would we do that? So that's the first thought. I'm going to go to the ingenuity of the nurses. They led the course here as what to do. For interventions, besides, like Jeff was saying, negative pressure rooms and trying to, meddle with the HVAC, doors to rooms that didn't have windows, solid doors, everybody privacy. Yeah, we had to cut windows into those doors. You needed that, communication. You needed to be able to see without going in. More storage for PPE. How do you gown in? How do you gown out? The nurses actually put tape on the floor to create a clean side from a dirty side, to create drop-off zones. So there was a lot of ingenuity on those interventions. A command center had to be created, a very large one. So all these should go into the new ones. And unfortunately, the outpatient clinics, we talk about waiting areas, they're all empty now, right? They're like, crosses on the chairs, and we all went to a lot of virtual waiting, and I'm sure it will come out later, but virtual consults, that's a bit. So for the developers, invest in HVAC. Like Jeff and I would do a lot of clinics in leased buildings, or they're not OSHPD buildings. We need that capability. We need more infrastructure.
Okay, fantastic. Jeff, Alex, Trey, anything to add?
Yeah, I
just, oh, sorry, go ahead, Trey.
I'm sorry. Yes, as far as the infrastructure, that's been one of the what's been keeping us very busy lately is going back through and evaluating as far as filterization, abilities to be able to change the air balance of these various rooms, accommodate these changes. And I think that's really been the hardest hit is, or the focal point right now is really dealing with the air changes, controlling that infectious environment.
Right.
That's
Jeff?
a good call out. Yeah, I was just going to say, Alicia mentioned the nurses. I can't let it go by without saying the collaboration between EVS and nursing, specifically in the units, facilities, oxygen, mechanical systems, working with administration to cohort patients in different parts of our buildings, depending on where they had the most airflow, for example. I just think the collaboration between all the teams from top to bottom, and for lack of a better term, I think was unbelievable. I've never seen it. And so this really was and I know that other systems, Alicia is nodding, we work closely with Cedars, obviously. But other systems saw the same thing. It's pretty amazing.
Do you foresee that continuing, Jeff and Alicia? Because that was an outcome of a very stressful situation. Do you see that collaboration continuing?
I was talking about command centers with those have changed from disaster command centers. We didn't talk about that. It was great that we all had tents because those were critical. But collaboration areas, like how your daily census is studied has changed, also in a collaborative, interdisciplinary manner. So there's a lot more, but it's going to stay.
Fantastic. All right. Moving to our next question, and this is for you, Jeff. Before COVID-19, there was a focus on reducing footprints and having smaller healthcare facilities to deal with urgent and daily patient visits. Is that still the case?
Well, I think so. I mean, the idea of, I'm going to say this, nobody please laugh, let's get the right care at the right time. We've been saying that for years, right? In the right location, right? So, take your broken finger to an express care, take your head injury to the emergency department, your orthopedist is sending you to one of Alex's locations to get your knee done, or your hip today. I think we still look at all of those types of things. The interesting thing about our market, right, Los Angeles, is in Holy Cross, which is way north, you've got a much different population than where I'm sitting here in Irvine, right? So insurances are different, education levels are different, resources are different. And then if you look at Northern California, that's a completely different market as well, because down here in LA, you need to have 4 to 6 physicians in a clinic, really to make any sense at all. So you try to consolidate your smaller clinics and make sure you can get some efficiencies from your MSO. The other, for Northern California, a lot of those affiliations are 2 doc clinics, right, in Woody Watkins, right? That would remind you of when you were in grade school. So it's a completely different market for us. So applying a standard across the board is difficult with a large geographic area and with a different cohort of patients. But no, I think we're also looking to find the most efficient way, whether that's to build urgent care outside my ED, so you can't go in, right? Or how do you divert appropriately so it makes sense for your providers, all those types of things. So I think the strategy remains the same. I think the implementation may be different, and our timelines may have changed a little bit as we look at building new towers, retrofitting existing, the 2030 burden that's going to be put upon us here, approach, the compliance for OSHPD. I mean, I think those timelines have changed, and our strategies have changed as we watched what we thought could never happen, which was revenue drop immediately. Reminded me of the banking crisis of 2008, right, where all of a sudden the money just completely stopped, right? So I think for our real estate friends and developers on the phone, you can't tell me you weren't worried about your rent, because certainly when we own buildings, Oregon, we own a boatload of buildings that are filled with medical providers. We're certainly worried about it there. So it's a very interesting time to make sure your strategies are all aligned and make sense for the cash flow that you're projecting.
Right. Right. Other comments on that question?
Yeah, I would agree. I think what we're seeing, as you all know on the phone, and Jeff, you and I have worked together, with some of the Providence projects, but we have the pleasure of working with a lot of the not-for-profits around California. It can involve Providence and Dignity and some of the UCs and Scripps Health. And what we're seeing more and more now, particularly when more and more cases, elective cases are now being scheduled in an ASC environment, we are seeing the development of, large-scale MOBs, multi-story MOBs, where you have imaging, you've got linear accelerators, you've got infusion bays, surgery centers, practices, all integrated as part of a multi-story type structure. And for a lot of the hospitals that have their traditional footprint in a certain geography, as they expand out 10, 15, 20 miles from the core hospital where they're doing all their tertiary and quaternary care, they're bringing these services to the community where their patients live and reside. So they're making it much more convenient to basically receive some of the higher acuity cases that or services that traditionally would be done at the hospital. So we're seeing a lot more of that, and that's really proliferating, not just here in the state of California, but throughout the West as well.
Yeah, that's why I have a job. It's the proliferation. I wanted to add to that I actually don't see the footprint shrinking. What I see is the right location, the multi-specialties. We had just developed our new model of care. Everybody has their own, and this got really hit by the pandemic, because rather than have physician offices, we had collaboration spaces with medical assistants, physicians, nurses, kind of like a pen, if you want, where they all collaborated. Was supposed to be much more efficient, and then COVID hit, and they can't work there. They cannot. Right. So that forced us to relook at the model. So that's still in development.
Very interesting. Very interesting. All right. We do have a question from our audience from Charlie Jocelyn. He asks, curious, are any facilities requiring ICRA certification? Alicia, would you like to take that?
All
our construction projects, we do.
Infection control, sure.
Yeah, I would. Okay.
Every project.
Okay. All right. Excellent. We'll move back to our fourth question here for Alex to start us off. How are medical office building design considerations changing during the shift to outpatient services?
That's a great question. And I think when we start looking at the shift that's been occurring over the last 5 years from hospital outpatient to freestanding ASCs, that really began well before COVID. And part of what's really accelerated that process is that now you've got Medicare and CMS really moving quite aggressively to start moving some of the higher acuity cases that have traditionally been done in the hospital into outpatient services. So for example, 10 years ago, if I would have told this group or stood before a large orthopedic group and explained that we would be doing a knee replacement or a hip replacement or a spinal fusion in an outpatient environment, then I probably would have been laughed out of the room, knowing that that was a high acuity case that would typically require a 1 to 2 or 3 night stay in a hospital. That is all really has changed quite a bit. And now when you've got CMS kind of leading that initiative and a lot of the commercial payers beginning to follow suit, we're predicting that by 2025, for example, on the orthopedic side, about 68 to 70% of all orthopedic cases will be done in a freestanding outpatient setting. And when you look at the change that's going to be required in that situation, we'll have to accommodate for appropriate OR room sizes. Traditionally, when you opened up a new center, the ORs potentially could have been designed to be 15 by 18. Now, everything that we do on a go-forward basis is going to have to accommodate the higher acuity cases. So the ability to bring in robotics, some of the microscopes that are needed for spine cases, that part of the design is definitely going to change within the ASC. And it certainly limits the types of MOBs that we look at as well. For another example, on the cardiovascular side as well, we have a lot more cases that are now approved in multiple states where you could actually do a diagnostic catheterization, do a stent placement in an outpatient setting. And that is available today in about half the states in the U.S. It does not include California today, but planning for a facility that has unistruts for the future adding of a cath lab are all important considerations as we look at centers going forward. So a lot of moving parts, and with the number of elective cases that were restricted as part of COVID as well, we are seeing more and more high acuity cases shift into the ASC setting. We're able to do those in a lower cost setting, and you're also able to do that in a quite an efficient manner as well. So just at a high level of some of the changes that we're seeing, but I'm sure Jeff and the rest of the group could probably comment to some of the other design considerations that they're looking at, particularly on the surgery side of the business.
Okay, excellent. Thanks, Alex. Other comments on that question?
Yeah, this has been a trend that has been going on pre-COVID, before COVID. And I think, Jeff, you hit on it when you said that getting the right service at the right time, this allows for that to occur. Is, now patients have more access to these other, on these outpatient facilities, things, treatments that you couldn't get, as Alex mentioned, 10 years ago. And now you don't have to wait to get access to a larger, more expensive environment in California. That's in the OSHPD. I know that's been one main driver of getting a lot of these services into these other buildings. I'm curious that now after COVID, if the reimbursement aspects, do you see any changes in that occurring on these facilities?
Yeah, so Trey, what we've been seeing really is the migration of these services from the hospital into the freestanding ASC. And traditionally, it's represented about a 50% reduction in cost, not only to patient deductibles, but also to the overall system. So from that perspective, we are providing, some cost savings. But unfortunately, the reimbursements, continue to race. Everything's racing towards Medicare rates in this day and age. So we're now having to handle higher acuity, more complex cases at a rate structure that's far lower than the hospital, and oftentimes just enough to kind of cover our basis and some of the implant costs as well. But we manage it. You manage it through maintaining efficiency, working with architects so we have an efficient workflow, and making sure that we can turn the rooms pretty effectively between cases. And by driving that volume, we're able to kind of make up some of the margin deficiencies that are out there from a reimbursement perspective. The nice thing about the trend, in particular with our model, is that we work very closely with our health systems. So as we start developing a cardiovascular program, an MSK orthopedics program, a vascular program, it really is a collaborative relationship with the health system. Many of our centers are joint venture with the health system so that we very strategically and systematically identify the right patient at the right location, and making sure that if we're sending a patient to an ASC, that it's the proper ASA classification, there's no airway issues, and safety and outcomes is always top of mind. So from that perspective, we continue to see very strong collaboration across the state with the health systems, and in really embracing, developing the right sets of services as these transitions happen over time.
Thank you. Yeah, that's good.
It's well said. For the cath piece, I think we talked about this last week, which I think is very interesting and feels very terrifying, honestly. Do you see that? Go ahead.
Sinai and Scripps are the two outpatient buildings that were new at the time that have outpatient path. We both do. But that was they didn't allow it afterwards. And the buildings are connected physically to the inpatient hospital.
And
they're all getting good results, but it's absolutely connected to the hospital. It's licensed buildings, but it's still outpatient.
That was going to be my question to Alex is do you see this being, 3 miles in Oregon is not 3 miles in Los Angeles, right? One is 45 minutes, the other is 5 minutes, right? So how do you think if this does get approved for California, will there be some location restrictions as part of the regulatory package?
Yeah, Jeff, that's a great question. And as I mentioned at the beginning, particularly with cardiovascular, there's a lot of activity happening in that realm. So about half the states today allow for diagnostic caths and PCIs to be performed. States like Washington, Oregon, there are some pretty heavy restrictions. And I can tell you right now, today, through the California Ambulatory Surgery Association, there is a bill being proposed at the Assembly for review right now to talk about those things: appropriate locations, proximity to centers of excellence, and really truly making sure that we are really kind of stratifying the patient population, the cohorts, and making sure that they go to the right place at the right time, and that you're really doing the easiest of cases in that particular setting and reserving the more complex cardiovascular cases for the hospital where they belong and will always belong. But we continue to work through that. There's a lot of great questions and a lot of physicians that sit with the California State Assembly today that are reviewing the bill right now. And, it's being obviously looked at very carefully. And I think we're probably still a couple of years out before we see any progress happen here in California. But I think as we look at it from a design perspective, I think we all have to anticipate that the addition of a cath lab or even an interventional suite is probably a very realistic service that will likely be shifting out of the hospital. Whether or not they allow cardiovascular cases to be done is one thing. There's quite a bit of work that can be done outside of the heart, and having the infrastructure and the unit struts planned in advance with the ceiling and everything else that you have to plan for is an important consideration.
Good point, Alex. Thank you. Great discussion. This one, Trey, you'll lead us off. What is happening with hospital expansions or new healthcare related construction? Are plans folding, being delayed, or changing in any way?
Well, one project we've been working on was started right at pre-COVID, and it did slow down just a little bit of a hiccup during obviously the reconfiguring and the lockdown, but we didn't see much of a slowdown. The teams decided, and the facility decided that, the funding's in place, the plans for real, let's make it happen, and we continued working on the project. So we haven't seen much of a slowdown, really.
Okay. Comments from Licia or Jeff or Alex?
Well, the money tree has less leaves.
Because you had the biggest impact, yeah.
The money tree has less leaves on it than it used to.
Yeah.
Or, Lisa said at the beginning of this thing is when we shut down elective surgeries.
Yeah.
So imagine that not only for a hospital as big as Cedars is, which is it's a big, big hospital, but think about that for 51 hospitals, right? Which is what our situation was.
Mm-hmm.
So certainly you have to realign and take a look back. Other states were not hit anywhere near as hard as we were here in California. So Washington, Oregon was more strict, so it took them a while to get going again. But Washington, ramping up, Alaska, Montana. So I think you certainly, the pro forma that might have been on the edge doesn't get approved today, where it might have gotten approved a year ago.
Mm-hmm. Mm-hmm.
We think that we're going to get some downstream here that'll amount to $5 million a year, which is going to make us profitable in year 3. That doesn't get looked at anymore. That's now like, proofs in the pudding. Your pudding is not very good.
Right.
But I think that's just a normal economic condition based on what we all faced, right?
Right.
So the good news is traffic's coming back, surgeries are back up, et cetera, et cetera. The big thing is how are people going to behave with EDs, cares, the revenue that was lost on procedures, are you going to wait the next 5-year cycle to have that done if you're healthy otherwise? Probably, right? Mm-hmm. You might get 90, 80%, 85% back, but that 10 to 15% care burden, right? That's where that's where the rubber meets the road for us. And we're not alone in that at the hospital. Mm-hmm. So I think to think that we're going to go on business as usual, and you're right, projects that are big and meaningful to communities or our replacement projects that have to be done, those have all continued. Tarzana, where at least our partners continues to roll along. We didn't see a bump in the road at all, other than with they got sick on the construction side, changing the entrances, clean, dirty, that kind of stuff. But we're still marching in lockstep there because that project has to get finished. Mm-hmm. But I think the other projects that are marginal, I think those projects get shelved until times are better. That's just my thought. Alicia, what do you see?
Yeah, I see all of that with, if you can imagine, just to give people a sense of a 900-bed hospital that was running at, well, actually we have 890 beds, but we used to have 900 patients, 870 patients. Suddenly you have 300 patients. Right. And the hospital is empty for months. Okay. Mm-hmm. So what we are watching carefully is cash flow. So Cedars-Sinai was fortunate to have saved for the rainy day. Here's the rainy day. Staff, we all had tremendous expenses on staff, but it's following the cash flow. So what Jeff was saying, some things are delayed to another quarter. If the business plan is not panning out, it's not going to be this quarter. It's going to be 3 quarters from now. So our construction program continues, but it's very regimented, what we spend. And the other factor is the unknowns that as owners we never liked. The market fluctuated. So what is the right time to buy? When do we bid the project? Is it getting cheaper? Is it getting more expensive? You hear both, right? So you might see owners holding back to try to see what the market is doing as well.
Right. Okay.
Yeah, I love the rebid. I love the rebid comment because we've seen both benefits. It seemed like there was a great window for that.
Yeah. And it's
gone.
We got one project in.
Whatever the next one.
Yeah.
We do have another question from Meredith. That question is, do you anticipate micro hospitals being approved in California? And if so, how will this affect your plans for MOB expansion and design?
Well, Alex has plans for like 10 of these already within a mile of where I'm sitting. Alex, you should take this question.
Okay, Alex.
Yeah, it's definitely a hot topic. Obviously, micro hospitals vary from a regulatory perspective on a state-by-state basis. It's hard to say. California is one of the tougher regulatory environments in healthcare relative to other parts of the country, but I definitely could see some value there. If you have had a chance to travel to some of the more rural markets that we have, up and down the Central Valley corridor and other pockets, certainly these micro hospitals make a lot of sense. I think they could certainly pencil out financially from a pro forma perspective. But again, I think the state of California has a lot to consider in a way with these coming to fruition. I think they'll use some of the successes they've seen in other parts of the country as a potential model for approval. But I do think that we'll continue to be a laggard relative to the rest of the country.
Okay.
I'd like to see standalone EDs first.
Yeah.
Because that would take a lot of burden off some communities for sure. And health systems having to keep a hospital open with 25 beds, critical access where they have a census of 3, that kind of stuff. So.
Okay. Great. Another question from Ryan. What areas in facilities or services do you see opportunities for better efficiency through use of new technology?
I'll jump in and mention, I think telemedicine will be a significant upswing. Again, with where we're at now, being able to address patient needs remotely with the restrictions that we have. So, IT infrastructure, that'll be huge. You're probably more involved.
Okay. Other comments on that?
Mm-hmm. Yeah, I would take that. I think if we can, I'm feeling this from somebody else because I'm in a group of about 15 people. We're talking about what our next build is going to look like. And so basically, because there's no idea, that's too nuts at this point. But one of the things that one of the folks brought up was, we need to bring the technology to the patient instead of bringing the patient to the technology. And that's harder than it sounds, especially in a traffic choked area like we live in down here. But the fact is, the efficiency you gain at a hospital, right? Elise is a specialist. She's going to see 8 patients in, 6 hours, right? So if you move that patient to Burbank, now that doctor sees 2 patients in 8 hours, right? So that's the challenge. But avoid building the technology and take it out into the field. The best PACU is your living room, right? Or the hotel that's next door that costs me $200 a night, not $1,500 a night. So how do we do that versus saying I'm going to continue to build $3.5 million a bed, right? With massive technology. But I think in all seriousness, you got to go back to utility use for that particular question. If I'm using an existing building, which Trey and Alicia touched on earlier.
We have another question here from Dina. How has this affected your moving forward with 2030 SB 1953 compliance? Are you moving forward?
We need OSHPOT here because they're changing it. So
Okay.
I don't know, Tuvina, that several of the hospitals with, our CEOs got together and they're talking to OSHPOT and they're talking about 2030 and they're talking about the inability of some hospitals to be able to comply in time, especially now, but even before now. So there's a lot of talks. I think, speaking for everybody that I know from the owner side, everybody's moving towards compliance. The question is, what does compliance look like? I mean, do we all need to comply in the same manner? Do we all have the same risks? We're not all in the same geographic area. Are we all going to fail at the same time? Can we transfer patients? So I think it's a bit more, the look is more comprehensive, but we just experienced a disaster, right? That wasn't an earthquake. So we're all moving towards it.
I would echo that.
Okay. Fantastic. All right. Stephanie, thank you to all of our panelists. And Stephanie, back to you.
Thank you.
Thank you guys so much. And thank you to the entire panel, as well as all of our speakers today. A couple of reminders for everyone still on. All of the videos will be available on demand within the hour after the session ends, so you can log back on after this and view any of the panel conversations that you may have missed. Please stay on as long as you'd like to continue to network and chat, as well as visit our wonderful sponsors in the expo floor section. You will receive a survey following this event. Please fill this out with honest feedback. We're always looking to improve and push the commercial real estate industry forward through these panels and our reality of online networking. Thank you again to our sponsors today. We really appreciate your partnership and look forward to continuing to work together this year. If you have any questions, please email me at stephanie.smith@bisnow.com. Thanks again, and everyone have a great rest of your day.
And now the end is near.